Okay, having considered the knee joint and the muscles acting at it, it's worth to consider the locking mechanism of the knee. This is an inherently incredibly stable position. A brief description of physiological versus accessory movements. A physiological movement is a movement that can occur actively at a joint. In other words, it's a movement that can be produced in isolation by primary muscle action. An accessory movement, on the other hand, is a movement that cannot be produced in isolation by primary muscle action. For example, an anterior glide of the tibia cannot be produced in isolation. Abduction at the knee joint cannot be produced in isolation by primary muscle action. However, these movements may be produced by an external force or may actually occur as an integral part of a physiological movement. So for example, when the knee moves from a flexed to an extended position, in order for that movement to occur, the tibia must move anteriorly, must glide anteriorly relative to the femur. If it doesn't, we end up getting a blockage of movement. Similarly, when the knee flexes, the knee must move posteriorly, or the patella must glide inferiorly. Accessory movements are important as without accessory movements, physiological movements cannot occur. It's worth looking at the spin, roll and slide handout that can be found on St Mary's Online to understand this concept further. Now, when we look at the muscles acting on the knee joint, we have muscles that can medially rotate the knee and muscles that can laterally rotate the knee. For example, biceps femoris, when the knee is flexed, biceps femoris can externally rotate the tibia. When the knee is flexed, semimembranosus, semitendinosus, gracilis, sartorius and popliteus can all medially rotate the tibia. However, rotation occurs also as an accessory movement during the final phases of extension of the knee. Now, this is brought about by tension in the passive restraints of the knee, but predominantly by the cruciate ligaments. So therefore, this becomes known as an accessory movement. And this accessory external rotation of the knee joint is an essential component of the locking mechanism of the knee. Now, when we look at the two cruciate ligaments, so here we can see a number of anatomical features. We've got over here, we've got the medial condyle of the femur, and we know that the medial condyle of the femur is longer and obliquely orientated compared to the lateral condyle that is shorter and rounder. In addition to that, when we look down on top of the tibia, we see the two cruciate ligaments. So here's the anterior cruciate ligament lying obliquely in the knee, and here is the posterior cruciate lying obliquely in the knee. When the knee moves from a flexed position towards an extended position, the cruciate ligaments will gradually increase in tension. Both the anterior and the posterior cruciate ligaments will increase in tension. And as this tension increases, the oblique nature of these two ligaments, the fact that the anterior cruciate ligament is orientated obliquely in this direction, the posterior cruciate ligament is orientated obliquely in this direction. As tension increases, it causes the tibia to externally rotate. So forces from the posterior cruciate and forces from the anterior cruciate create this external rotation of the tibia. The shape and the orientation of the femoral condyles further permits this motion. The fact that when we go towards the final phases of extension, because the lateral condyle on the femur is shorter and rounder than the medial condyle of the femur, it will reach its terminal phases of extension before the medial condyle does. As a result of which, the medial tibial condyle has further to travel, further enhancing that external rotation movement. When rotation occurs by primary muscle action, in other words, physiologically, we call this rotation an adjunct rotation. In other words, we have an additional degree of freedom. But when rotation occurs as a result of tension in the passive structures of the knee, or indeed of any other joint, in other words, it's an accessory motion, this is known as a conjunct rotation. In other words, it is a movement that occurs in conjunction with something else. So, for example, the lateral rotation that we see at the knee occurs in conjunction with extension at the knee. So that brings us on to the locking mechanism of the knee. So as we continue to extend from a flexed position, the increased tension in the cruciates, or we see an increased tension in the cruciate ligaments, and the obliquity of the cruciates pulls the tibia into external rotation, into lateral rotation. So here we can see the ACL pulling in this direction, PCL pulling in this direction, and this is aided or facilitated by the shape of the femoral condyles, by the asymmetrical shape of the femoral condyles. This rotation then causes an increase in the tension of the collateral ligaments, of the medial and lateral collateral ligaments. And so we've got increased tension of both cruciate ligaments, we've got increased tension of both collateral ligaments, and the tension in these four ligaments draws, it pulls the tibial plateau and the femoral condyles together. So we see an increased compression between the articular surfaces, and as the femur is driven down onto the tibial plateau, the menisci open up to accommodate this downward movement of the femur itself, and so we see a slight deformation of the menisci. In order to unlock the knee, we have to come out of this laterally rotated position of the tibiofemoral joint. This is partly brought about by the recoil of the ligamentous structures and partly brought about by contraction of popliteus. The locked position of the knee is an incredibly stable position. There is a lot of tension on the passive restraints, there is tension in the muscular restraints, and there's a lot of compression between the articular surfaces. It's a very stable position of the knee joint itself. That medial rotation must come about before the knee can be fully unlocked. This is something to heed when coming to test the strength of the quadriceps, for example. When you actually test the quadriceps with the knee fully extended, you've got to be aware that the pressure, the tension, the load that is going through the articular surfaces and the inert structures can potentially lead to significant damage. So when testing these structures, it is important to unlock the knee before we start loading those structures up. This is popliteus. Popliteus is a small obliquely orientated muscle across the back of the knee. So this is the posterior aspect of the knee joint here. Here we can see the lateral aspect of the knee joint. Its proximal attachment is from a small facet, a small groove on the lateral aspect of the lateral femoral condyle. It is found inside the boundaries of the capsule. So it's got an intracapsular tendon, so it actually pierces the capsule. So as popliteus itself moves from, comes around from the posterior aspect of the tibia round to the lateral femoral condyle, it pierces the capsule and actually slightly grooves the lateral meniscus as well. Its distal attachment is on the posterior aspect of the medial condyle of the tibia. So there's our medial condyle, and popliteus attaches onto the posterior aspect of the medial condyle above an oblique line here called the soleal line. And the function of popliteus is that as it contracts, it will pull that medial tibial condyle backwards and therefore encourage unlocking of the knee and flexion of the knee joint itself. Popliteus is a small muscle. It can be palpated through some of the more superficial soft tissues, and whereas some time ago we used to ignore popliteus as a potential source of symptoms, popliteus can become injured in torsional injuries or twisting injuries of the knee. For example, skiing or twisting on a planted foot.